Hi, everyone. I'm Frances Padilla, President of Universal Healthcare Foundation of Connecticut, and I'm delighted to welcome you to today's dialogue about connecting communities, health, and care beyond the pandemic. Before we begin, I want to thank our sponsors and supporters, Eastern Connecticut Health Network, Donahue Foundation, Connecticut Health Foundation, and the Connecticut Community Foundation. We appreciate your partnership in this exploration of how we can and must collectively move beyond COVID. EHCN has a short video message for everyone that we would like to share with you before we get started. So Jackie, take it away.
Hello, I'm Deborah Weymouth, CEO of Eastern Connecticut Health Network and proud sponsor of today's presentation coordinated by the Universal Healthcare Foundation of Connecticut. Thank you for joining us to hear more about how healthcare providers across Connecticut are expanding ways to promote high-quality healthcare that's affordable for everyone. We believe in providing exceptional and compassionate care for our region. And we also believe in providing helpful tools and information to stay connected and informed about healthy choices. Our mission is to partner with you in making healthy happen for you, your family, friends, and our community. I hope you enjoy today's discussion. Thank you.
Thank you. Today marks Universal Healthcare Foundation's 21st birthday. We've spent the past 15 months experiencing a worldwide public health crisis play out in our own backyard and witnessing the adverse impacts of the deep racial inequities that are baked into our healthcare. As we enter our third decade in the face of these tectonic shifts, our board and staff feel a strong call to meet the moment. As a start, we've adopted a new long-term goal to build grassroots power for health justice by collaborating with broader racial, social, and economic justice agendas and movements. We'll have more to say about this over the course of 2021 as we collaborate to co-design how we will meet this goal. Like everyone else, last year we held a series of dialogues on issues pertinent to COVID-19. These were so well received, we decided to continue them in 2021. Today's conversation is one of 4 this year. These are intended to consider what the lessons of the past 15 months tell us about the future. Can we rise from the ashes to forge policies and practices for a Connecticut where all residents can be their healthiest, regardless of race, ethnicity, zip code, income, or immigration status? And can we forge into existence a system that equitably nurtures health? Today, we're exploring the role of community health centers in this. Other dialogues in the series will explore the roles of public health, hospitals, and behavioral health systems. I have the pleasure of moderating this conversation today with Nichelle Mullins, President and Chief Executive Officer of Charter Oak Health Center in Hartford, and Joanne Borduas, Chief Executive Officer of the Community Health and Wellness Center in Torrington. These 2 powerhouse women are leaders in the world of federally qualified health centers, serving communities that have long been disconnected and underserved by the rest of the health system. From each of their unique perspectives as the CEOs of centers in an urban environment and in a rural environment, Nichelle and Joanne will give you a sense of their organizations and the communities they serve. One last thing before we start. We want you, our audience, in the conversation. Please enter your questions in the Q&A function at the bottom of your screen to the left of the chat button. We'll try to answer as many of your questions as possible. And now, let us begin. All right, so I'd like to start with a question for each of you, Nichelle and Joanne. Would you, at a very high level, tell us the most important things you want us all to know about the Community Health and Wellness Center and the Charter Oak Health Center and the communities you each serve? And in what ways, so it's a 2-part question, 3-part question. In what ways did the brokenness of the health system show up during COVID in your respective environments? So I think I'd like to start with you, Joanne.
Sure. First, let me thank you all very much for inviting me to attend this very important conversation. It is a pleasure to be here with you, and I'm happy to tell you a little bit about our health center. Community Health and Wellness Center is located in Torrington, northwest part of the state. We are probably one of 3 of the smaller health centers in Connecticut, but enjoy a very collaborative relationship with other community health center and my peers. We service a population of about 6,000, which equates to 30,000 visits per year. And like most community health centers, we are really established here in Torrington as a safety net provider for our community. So for those patients who may be insured through Medicaid or uninsured and have difficulty accessing care elsewhere, we are sure that we make sure our doors are open to receive them and provide them the care that they would not otherwise receive. We have 2 locations here, one here in Torrington and one in Winstead, again, to serve the same purpose. And we are hopeful that we will establish a 3rd site in the area of North Canaan in the very near future. That area is also an area where primary care is very much lacking and resources are scarce. So we're very excited to be able to branch into North Canaan and assist with providing quality health care. I think we were established in 2003. The population here in Torrington is approximately 35,000. So it's not a large city, but it's big enough where we do have disproportionate burden of chronic diseases relative to the general public, and that does get enhanced due to our geographical location. And while Torrington may be smaller compared to some other even rural sites, there is quite a distance between our center and the other side of town, if you will, where we know there to be at least 5,000 to 6,000 patients who are unattributed to primary care providers in this area.
When you say unattributed, you mean that they're not connected to a source of primary care?
That's correct. And so the way they receive those services are through urgent care centers or in the emergency departments of our local hospital. And of course, that is not the ideal way to receive primary care, especially when there are concerns for, again, chronic disease management and continuity of care. So we will be hopefully reaching out to that area a bit more through the use of our mobile van, which we are about to get out on the road soon. But disparities do exist in local towns, and sometimes the challenges of being a small community is even greater than being in an area of a larger community. So one of the barriers that we really find difficult here and contributes to gaps in care is transportation. There is a lack of transportation here in the Torrington area and really the northwest part of the state. So aside from some voluntary transport systems, we are left with offering patients vouchers for cabs or community things like VEO in order to get them to our health center. And so that becomes a very large challenge. Poor infrastructure, sometimes related to both transportation and other access issues, contributes to folks not being able to readily access healthcare services in general. So we see our role in the community as critical piece to ensuring that we do meet those needs. And most of us are set up as one-stop models. So when we do our community needs assessments, we understand what the community needs, and we try to incorporate those needs into the services that we offer so that we can make it convenient for the patient and address those barriers such as transportation, knowing that going to multiple sites to receive their care might actually be difficult. So we, for example, have a pharmacy in-house, we have an on-site lab, we offer the core services of medical, dental, and behavioral health. We have some specialties on site, such as chiropractic and podiatry, and we're looking at some other options moving forward this year. And again, those are based on what the public and our community is telling us they need. 65% of our population are benefits of Medicaid. And so, those issues of barriers are compounded even more so with their inability to access specialty services or even just care in general. So we work very hard to collaborate with our community-based agencies and partners who we've strengthened our relationships with as a result of COVID, which has been extremely important and critical in order to keep connected with our patients and ensure that we continue to meet their needs through a crisis. Oh, Francis, I think you're muted.
Sorry about that.
That's okay.
I wanted, I was trying to say that that we're going to talk a lot about relationships as we work our way through this conversation. The very existence of your health center as a federally qualified health center does have a lot to do with these disconnections that people in the community have to healthcare services, and the inequities, right, that represents existed before COVID. And so before we go into actually how the brokenness of the system showed up and has shown up throughout the COVID experience, let me switch over to Nichelle and ask you, Nichelle, to set the context of what the Charter Oak Health Center is all about and the community it serves, so that we all have a good picture of these two centers, your communities, different and similar in a lot of respects, right? And also, I should say that you are two of, am I correct, 13 or 15 community health centers that are federally qualified in Connecticut. Am I correct on that? 17. Okay. So there are community health centers all over our state. And I think some of the people in our audience may know that, but some may not be aware that you're really part of a larger system.
Mm-hmm. Yeah, and speaking to that, collectively, I think we serve about 400,000 patients in the state. So that's a pretty large population. So our story, Charter Oak's story, is very similar to Joanne's story. With her clinic, we started in 1978 in a public housing project because the patients in that community didn't have direct access to healthcare. And many people remember there was a time where there wasn't free, just accessible care. So you had to go to the emergency room for your care. And so those patients decided that they didn't want to take 2 buses anymore. And they were innovative trailblazers who decided to go to the housing authority and ask to use an apartment building to open a clinic. And that clinic has transformed into what Charter Oak is today, which is an organization that serves about 20,000 patients annually. We have 16 sites throughout Greater Hartford and in Bloomfield. We are a healthcare for homeless grantee. So that means we serve, we have some sites in homeless shelters, and we serve the homeless population in Hartford. We are also a public housing grantee. So being as though we started in a public housing project, we still have close connections with residents of public housing. We offer the same services that Joanne's clinic offers, and which is medical, dental, behavioral health, pediatrics, women's health, radiology lab, podiatry, chiropractic. And then once we looked at some of our patients' needs in terms of healthcare and their difficulty in accessing specialty care, we brought on a cardiologist, pain management specialist, as well as optometry. And we continually look at our patient needs in terms of specialty services to determine whether or not we should widen that service area. And the issue is a lot of our patients, so I would say 60 to 65% of our patients are Medicaid recipients or beneficiaries. And then there's a large population, about 20%, that are underinsured or self-insured. And so they don't have the same access to specialty services that someone who has a commercial plan would have. And, or even if they have, they can find a specialist, which is very difficult, who will accept Medicare, Medicaid, or uninsured patients. They don't have the transportation to get to those offices. So even bringing in a specialist once a month has dramatically improved the outcomes for our patients. We also have a urgent care department. Joanne spoke about this. You know, many patients, if they are working, they can't get to their provider between the hours of 8:30 to 5. So many of the health centers have extended their hours until after 5 o'clock, maybe 6 or 7 or 8 o'clock, to give those individuals who are working the opportunity to see their provider, or even on the weekends. We have an urgent care department that is open 7 days per week and until midnight on Fridays, Saturdays, and Sundays. Because we are in Hartford and we have two hospitals, two major health systems, hospital systems right in our neighborhood, we found that it was a need to extend our urgent care hours so that patients were not going to the emergency room after hours for routine medical care. And we saw that during the pandemic, that having those extended hours really did help provide access to care. Sometimes it was just questions that people had about COVID. They couldn't get their questions answered over the phone, or even if they tried to show up in person at one of the emergency rooms, they didn't have access to care there. So that has been really helpful. So I'm looking at my notes to see if I left out anything. So that's just a nutshell of where Charter Oak is right now, and we'll get into more of how our operations have transformed during the course of the pandemic.
Well, yes. So let's go there. COVID. So first, I want to say, right, like in both cases, we're really talking about a pretty innovative system of care that meets people where they are. That's what I take from that. You meet the people in your community where they are, and you go to them too, right? You make it possible if they need to go at midnight on a Saturday night, or if you have to go out by mobile van to see folks. And so then COVID happens. So, you know, each of you reflect for a couple of minutes on like, what were those first few weeks like? Few weeks, couple months like for you? And for your
yeah, so it was frightening, I think, like it was for most, because I don't think that any of us thought that we would ever be dealing with something like a pandemic in this day and age. And as much as we all participate in emergency preparedness in our own geography and statewide and with local municipalities, you know, we always think we're ready, but to have to put all that into play in a matter of days and weeks, I don't think that anyone was, you know, prepared to do that and approached it in such a way where it was, oh, just another task for the day. So I know that one thing for us was, you know, we had been talking about telemedicine for a long time. Some of the barriers to really getting that put in place was the state of Connecticut, you know, unfortunately didn't reimburse through Medicaid some of the telemedicine services that we all would have loved to pursue. But COVID created a situation where we had to suddenly become expert in how to deliver care via a telemedicine mode. And so our providers suddenly had to know how to do that. Our patients had to be educated on what it meant to be able to access their provider in such a way that was very different than what they were used to. And then we had concerns for patients who didn't have the technology or, you know, within their home or couldn't afford the technology to be able to do telemedicine via video. And so we went to moving to all telephonic visits for some folks as well. So the challenges of, you know, perhaps even bandwidth issues in a rural community that became really a concern for us, and we had to react to very quickly. Luckily, we were able to get some funding to help us with that. But even just having basic necessities like the ability to have enough remote equipment for folks because they all now had to leave the office and go home. And some of our providers and staff being in Torrington live in even more remote areas, 30 miles away from us, where connectivity issues presented a problem. So then we had to switch gears and say, okay, well, how do we deal with this? And we had to bring some of those folks back in, working out of a private office so they can get connected to our patients. And I will say that, with that came a lot of innovation. As Nichelle had mentioned earlier, we got very creative. What would have probably taken us another year or two to keep talking about telemedicine and how we get that done, we got it done in 3 weeks. And I don't think any of us ever thought we could do that. And now it's just become an enhancement of how we connect with our patients. And during COVID, the telephone only ability to stay connected with our patients really became a lifeline for the behavioral health patients in particular. If we weren't able to call them on the phone for those individuals that didn't have video capability to do a visit and make sure that they stayed connected with us, those are the folks that we hear about today that may have experienced even bigger issues and worsening of their mental health issues because of feelings of isolation and not staying connected with their provider and not being able to maintain that regimen that has become so much a part of their life in order to get them to wellness. So I would say that was the biggest thing for us, is learning how to become expert, which I think, there's always something to learn, but we are all very close to that now when it comes to telemedicine.
The learning curve was very sharp, for sure.
Yes.
Nichelle, how about you and Charter Oak?
Very similar. So my administrative team, we started meeting, I think maybe the first week of March, just trying to get ahead of what we thought at the time was going to happen, but none of us imagined it would be this. So we started looking at our employee list to determine who could work remotely, who could stay, and then we started looking at what our operating procedures would be in terms of how we would see patients, how or whether we should decrease the footprint in the building, because we were seeing at that time anywhere between 500 to 700 people a day coming in and out of the building. So we had to quickly think about all of that. And I think we probably met, if you asked my team, we were in meetings for 8 hours each day for a good week. So we could come up with plan A. And then, that changed to B, C, D, and I think we're on like triple numbers now because everything just started changing so quickly. But I feel like we had, as an administrative team, we had a firm grasp on how we wanted operations to change, but things just didn't cooperate with us in terms of not having, we had the best plans to send people home to work remotely, but we could not find phones, computers, iPads, cameras. There was nowhere to find them. It didn't matter how much you were willing to pay, you could not find them. And then we were running out of PPE. I'm sorry, what did you say, Fran?
There was a rush on all of those kinds of things. Yeah.
Yes, and then we were running out of PPE, and Joanne knows this story. All of the CEOs from the health centers got together, and we just said, okay, how are we going to do this? So when you talk about collaboration, I mean, we started, do you have this size? Do you have that size? I can ship this to you. And we started figuring out how we could all keep our doors open, because we knew that if any of us close, our patient population would go immediately to the emergency room. And they wouldn't be able to handle it. And so there was just a mad rush of meetings and planning and, everybody wear whatever you want to wear to work today, just as long as you come back. So we can figure out how to keep the doors open, because we knew that our patients were still going to need their prescription. They had, multiple chronic conditions, so they needed access to their providers.
So here's the thing, if I can interrupt you for a moment, like I'm hearing you say, it was COVID. Yes, it was about being worried about whether you had the symptoms, whether you needed testing, but it was also the regular care of people with chronic illness,
Yes.
multiple chronic illness, who were not for being connected to your clinics, your centers might not. And so really, in some cases, even life or death, right? Because
Definitely. I mean, people were calling and asking questions about COVID, but people were asking about their medication and, their asthma treatment and, how were they going to see the pain specialist and how was their child going to have their wellness checked? Those things still needed to continue. And there was no way that any of us could put that on pause for a year.
Mm-hmm.
We just couldn't. So we had to figure out how to we all operated, and I say all of us, 17 of us, we all operated from the perspective that there was no way we could close. Now, some of us had multiple sites, so we may have closed down those sites, but those patients they all went to the site that was open. So we
Sure.
all knew that we had to keep our doors open, that we serve a patient population that deserved nothing less and required nothing less because of the types of conditions that they had. They needed to be in touch with us.
So I think you've set this up really well for a discussion, like moving into the next part of this discussion, which is about the way that we think of healthcare as a system, but it's in fact very fragmented and very siloed. Every institution doing its own thing. And with COVID, you've just described a system among the community health centers across the state where people were like on call, right? Helping each other out. And
sometimes
COVID,
crying.
Yeah.
Each other.
I can imagine the stress levels, and we're going to talk a little bit about the PTSD, the mental health, both in the larger community, but also within the health care provider, within the centers, right? But I'm hoping that we can get to that. The question I would really like to pose to you both is about this issue of the silos. Like, did COVID bring organizations into working together in new and unexpected ways? I mean, both on the good and the negative side, right? Because sometimes you depend on some partners and they don't show up for you. But without, I think we need to understand these things and unpack them as we think about what the lessons are for the future. So would you start off, Nichelle, and reflect on that?
Yeah, definitely. And I think the question was perfect because I think the people that we thought would have shown up did not. And it was the unassuming people or partnerships that emerged that were just so wonderful. And I'll give an example. There's 17 health centers, so 16 of us are part of CHCX and the Community Health Center Association of Connecticut. And the 16 CEOs started having weekly calls. And all of us were extremely busy. You just heard Joanne and I say all of the things we were trying to juggle, but we took 1 hour out of each week to talk. And then our operations people were talking and our CMOs were talking. And we just tried to brainstorm and figure out what we needed and how we could help each other and how we could get things done, whether it was PPE, whether it was funding, whether it was trying to get in front of the governor to show how we could be a resource or an asset, testing, and now vaccine. That partnership has grown stronger, and we're all scattered across the state, but it doesn't feel like it when we're on the phone with each other. And Charter Oak partnered with Trinity Health of New England, which has been a wonderful partnership, and that's where we started our mobile testing program. And so we've been going out in the community testing together, and that has been a valuable partnership. And then, the other partnership with the faith-based organizations, the community-based organizations, some of the people who were in the community who just decided to start feeding seniors, and then that evolved into feeding families. We partnered with them. It's just been a wonderful show of support. And people will just call and say, what do you need? Well, I have some face masks that were donated to me. I can give them to you. Or our organization made 100 face masks. Can we donate them to your staff? or we'd like to donate lunch to your staff. So things like that have been so meaningful for our staff.
Sense of
And it's just
community.
showed like this sense of community and belonging, and we're all in this together. That's been helpful and has been encouraging throughout this pandemic.
So what's worked and what hasn't, Joanne? What in terms of these relationships, these partnerships?
Yeah, so I echo Nichelle's sentiments. Key was the networking that we have done, amongst one another to figure out what was working well and what wasn't. But also in a community, in a more rural sense, our community came together so well, really in the interest of our residents here, and in the interest of wanting to make sure that, for example, people were getting tested when they needed to get tested. Now we're focusing on vaccinations. But so our fire chief, in town decided he was going to lead the effort on getting us together and committing myself, him, the Torrington Area Health Department, our local hospital, Charlotte Hungerford, who is also Hartford Healthcare System, and so many other community agencies, the mayor, who, was very dedicated to getting on the phone weekly and saying, okay, who's doing what do we need to do better, and what's missing, and where are the gaps? So that was one great thing that came out of this is, again, as I mentioned earlier, strengthening the relationships, because in a pandemic or any crisis, the response needs to be a community response if you're going to do it well, and if we're not going to be kind of moving off in different directions. And so what didn't go so well in the very beginning, because I think, again, none of us anticipated needing to know what to do when a disaster really happened, was that we did start doing that. We started going off in different directions because I think, as you mentioned earlier, Francis, unless there's strong community effort, it's very easy to work in silos. And so initially, I think we were all so caught up in needing to know what we had to do to get past the first few weeks that we started planning on our own rather than as a united group. Until we recognized, hey, we're duplicating efforts and we're needing resources to get this done, and the only way to best approach that is to do it together. And once we learned that's the best approach, it really was much easier from there. And we learned in a small community with not a lot of resources that we could really rely on one another and get the job done.
And that the larger service to the community was really the uniting force, right?
Exactly.
Well, so we have a question actually that I'm in the Q&A that I think would be really great at this point. What innovations, Nancy Yedlin actually asked, what innovations have you adopted during the COVID crisis that you'd want to preserve and build upon going forward? And what kinds of policy advocacy support do you need to make that possible? Good question.
Yeah, I think I alluded to definitely, looking at different ways of delivering care. In situations where you have to kind of stop what you're doing and tell patients, listen, you can't come in, or if you do, you have to wear masks and you have to stand 6 feet apart and do all these things that, we needed to do. But I think in terms of being innovated, again, it was how do we approach those individuals who need to stay connected to us, who are concerned about coming out, who actually have an anxiety and a fear of COVID that has really impacted people differently across all sectors. Patients, staff, everyone just has dealt with COVID in their own way. And so again, learning how to deliver those healthcare services in an atypical way. So whether it be, we're going to do it, provide mobile phones to patients, for example, so that we can give you the technology you need, create a resource center within our center so that if you don't have connectivity, you can come and we can help you. In terms of advocacy, I think, what we all kind of move to the table with together as a group of FQHCs is, how do we get paid to keep our doors open, to do things like deliver care in a different way. And usually when we're talking about policy, it's things like, working with the state to help continue telemedicine. That has really been the topic. And Nichelle, I'm sure, can add to that. But that has really been what we're all really focusing on right now, because I think we and the state has learned and hopefully seen the outcome of being able to stay connected and how important delivering that care in a different way is to certain patients that could really use it during a time when, again, we're saying don't come out and stay in your home, but we still need to provide care for you.
I was definitely going to add telehealth and the audio only visits have been extremely helpful for our patients. And so in terms of innovation, Joanne, she hit the nail right on the head earlier when she said, for so long, we were hearing FQHCs can't do telehealth, we can't bill for telehealth. And then we were thrown in a situation where we were able to respond quickly, get the equipment needed, train our staff, and then try to train our patients how to use telehealth, whether it's a video visit or audio visit. And we did that very quickly and our patients appreciated it. And it really cut the no-show rate. So especially for behavioral health patients, they were keeping their appointments. They didn't miss their appointments for a variety of reasons. And so those are huge areas that we're still focusing on. I think the other two areas that I would touch on would be integrated care, the need for integrated care models and payment reform for that, so that we can have a medical provider and a behavioral health clinician in the same room providing care for a patient, and there's some reimbursement for that. And then the last one would be prevention and wellness. A lot of questions that you hear now is, how can I take better care of myself? Are there any vitamins or any other types of holistic approaches that I can take to avoid COVID or prevent serious illness or death? And there's not enough in terms of payment or reimbursement for providing that type of information. Everything in medicine right now has been so reactive. So I'll treat you once you get sick. I'll treat you once you get the diagnosis and I'll prescribe. But you have a lot of people who are asking, how can I avoid becoming sick? And providers they'd like to have that discussion, but they can have it in limited segments or doses because they know they have to see patients in order to be reimbursed so that they can pay their overhead costs. So those are a couple of areas that I would just add to what Joanne mentioned.
Yeah, and I agree with Nichelle. The integrated care in particular is something we've been working toward for a long time at the request of the state through many initiatives, and yet it becomes very difficult to kind of move that forward when you don't get paid to be able to give the care in the right way.
Is there a difference between an urban place like Hartford and a more rural area like the Torrington area, Northwest Connecticut, I should say, with respect to the delivery of an integrated model of care? Is it harder in a city like Hartford or in a rural area to bring these different providers together and to make the case together on an advocacy level for their integration and the payment to support it?
And I'll start quickly, but I think both are challenging. Our challenges are just different. My challenge is, it is very difficult for me I'm in competition with two hospitals. So they have the ability to recruit. They have more resources to spend in recruitment and salaries and retention. And so I always have to sell why it's beneficial to come work at a community health center, because I have these two hospitals that I have to compete with. Once I get them in, it's up to me to keep them. And we can do the integrated model because we have them in-house. The payment always becomes the issue. And I don't ever want to sound like it's all about money. But when you have, two high salary individuals providing services to a much needed service to a patient and you can't get reimbursed for it, at some point that takes a hard hit on your bottom line. And then you got to start thinking about, how do I reduce services in another area, reduce staffing, reduce my overhead so that I can maintain that level of care. And you never want to be, I always feel like I'm playing chess with people's lives at stake, and you never want to be put in that position. And I know Joanne has challenges, but hers are just different because she's in a rural area. So go ahead, Joanne.
Yeah, so, and I mean, much of what Nichelle just said are my same challenges. I don't have two large hospital systems here. I have one. However, my recruitment challenges are very real, because when you talk to folks about coming out to Torrington, they're like, Torrington? Where is that? Where? And so I usually have folks traveling sometimes up to an hour or more. When, you know, I'm looking to recruit the higher skill level, so providers and APRNs and nursing staff. Very rarely do I get anyone locally. And that really becomes my challenge. And as Nichelle said, you know, we have a local hospital here who we enjoy a very good relationship with, but they can pay those types of providers much more than I can. So they're either going to go to the hospital or they're going to come to me. Those are the two, we're the two largest employers in this area. And so, you know, sometimes money is a driver for folks, especially the new providers who are getting out of school or want that hospital experience before they really figure out what their niche is or what they want to do. So recruiting things like psychiatry is almost nearly impossible here. Somehow I really lucked out and was able to do that the last couple of years, but it is a great challenge in a rural area to recruit highly skilled, high-level providers. And, you know, it's hard to maintain processes without the ability to do that.
Mm-hmm.
So really the ability to create a more people-centered system does also relate to the relationships between organizations, right? Relationships that you have, not just with other healthcare providers, but also with other community-based resources in the nonprofit community, in the faith community, in the philanthropic community.
Right.
You have to have those relationships, and so and advocating for reimbursement on a sustained basis. I mean, we saw in the earlier days of the pandemic when the telehealth visits for behavioral health were not yet being reimbursed by commercial insurance, there was a hue and cry by behavioral health providers who said, wait a minute, you know, we've set up our ability to continue to see our patients need us, and we need to be reimbursed fairly, right? Fairly. And it happened on a voluntary basis because the governor said, okay, why don't you play nice? Let's do this. I believe that's the case. It has continued. The question is, will it continue into the future? And what we're talking about here, telehealth is a very good concrete example. And some might argue, right, that not all health services lend themselves to telehealth for a variety of reasons, both from the patient perspective and from the healthcare provider perspective. But it is another tool in the toolbox. That's how I think of this, yeah. Right? That can increase access for folks. And so keeping it is important. Now, the integrated care, we have models of that in Connecticut, in the country, integrated care where behavioral health, medical health, and oral health are all under the same roof in a coordinated way. But those are models that are the exception, not the rule. And so the relationships that are needed to advocate for these changes in a deep and real way are really important. So my question for you right now, as we think forward, is think ahead to the future, is what are the kinds of relationships that should be existing on an ongoing basis in order to really turn this system of fragmented players into a much more synergistic and coordinated system that has the patient in the center. Talk about relationships and what do you think you've learned about them?
Well, I mean, I can start just by saying, in a broad sense, I think that some of the payment policies, if you will, to just start there, really has a lot to do with maintaining relationships with our state and congressional delegation, because I think that there is still a need for education among many in terms of what do we FQHCs do. And I think that, and I've heard this so many times, and I'm sure I chuckle, and I'm sure it makes my peers and chuckle when people think that we are just have all this endless money as an FQHC for some reason. And the reality is we operate on shoestring budgets. And, we all want to get to a place where perhaps we're not so dependent on grant funding to, make sure that we can sleep at night. But the reality is we have to rely on some of that funding in order to, for example, get new services up when we discover there's a need in the community, or when we want to expand services like in psychiatry where we have, high cost salaries and we want to move forward to provide care with these, evidence-based models that we know are best practice and provide the best outcomes. And so I think, we shouldn't have to maybe fight so hard to get paid for what we do because we need to keep our doors open. And that is just part of our mission and what we work so hard to do. To Nichelle's point, it's not about the money, but it is in order for us to do what we have to do for our patients and for our community and meet the expectations that everyone has of community health centers to care for the underserved. And when we can't do that, because we're constantly, trying to fight against what we think we should get paid versus what others think we should get paid. I mean, we shouldn't have to really argue about getting reimbursed for vaccinations because that's a preventative health measure and we should be able to do that. If we're set up as a model of convenience for patients to eliminate some of the disparities and the barriers, we should be able to have the patient go see their primary care provider and then go down the hall and see the chiropractor. But some of those rules are very prohibitive in, getting done what we are all established to do. And I think there's a great need for more education out there so that folks, policymakers understand really what we struggle with to make sure we're doing what we do.
So actually along those lines, and I want to direct this to Nichelle. So in terms of policymakers and decisions, the decision to vaccinate by age criteria affected vaccination rates in urban places for certain in a very different way from vaccination rates in other places. And these are policies and practices. Some populations within each of your communities have been hit harder than others by COVID and have been getting hit harder than others by all kinds of other health issues. But the changes that are needed, and I know that Hartford has a story, you're part of that story at Charter Oak about this vaccination approach that really would be, I think, illuminating to all of us today about ensuring that people aren't so vulnerable to policies and practices that don't make sense for them. Mm-hmm. Can you talk a little bit about that?
Sure. I can say that the COVID exacerbated and highlighted social determinants of health for so many reasons. And what we see in terms of COVID impacting communities of color, vulnerable communities more than other communities is really related to the social determinants of health that providers have been screaming about for years. And so COVID was a blessing and a curse because it kind of said, it shined a light and said, look, these people are dying at higher rates because of housing insecurity. food insecurity, safety issues, transportation issues, educational issues, employment issues. And it's not just because they're Black, it's not just because they're Hispanic, they're not dying just because of that. It's a mixture of all of these systemic barriers or disparities and equities that these communities have faced for years. People who live in poverty, regardless of color, they've faced these things for years, and COVID just came and shined a light on them and said, okay, now I'm going to target you because you're living in cramped conditions. You're living in an apartment where there are already environmental concerns, and there's a landlord who doesn't really care. Nobody's paying attention. And so that's what we were seeing a lot in Hartford. And very early in the pandemic, the mayor declared that every resident in Hartford was considered at risk, which was really helpful because that gave us the opportunity to offer testing to everyone. And, you know, in terms of the age rollout for the vaccine, you know, the vaccine advisory group was widely following ACIP's recommendations, the CDC recommendations on the phasing for vaccines. But there was a lot of discussion around, a lot of discussion around ensuring that whatever decision or allocation method that Connecticut used, it had to include and have a focus on equity. And pretty early, you really, it became apparent that many people did not understand what equity meant. They talked about distributing vaccine equally, but equality and equity are two different things. So you can send 50 doses of vaccine to each town, and that's an equal way to distribute vaccine, but it does not address equity because while you're sending 50 across, more people are dying in one specific town. So you might not need to send 50 to every town. You might need to send 150 to one town and 10 to another town. And that's how you address equity. And those concerns were not really, those concerns, those questions, they weren't adequately responded to during the course of this whole vaccine discussion. And it has been incredibly frustrating, incredibly difficult because you still see the numbers increasing. And while every day the governor announces what the statewide average is, those of us who are in FQHCs know that our positivity rates have always been over 10%. They continue to be over 10%. And so the statewide average might be at 3 one day or 2 one day or 5 one day, but they're still high in our areas because we are all located in underserved areas where the social determinants of health are prevalent. And so if we want to talk about how we move forward or how we change the system, there needs to be an acknowledgement that social determinants of health exist, and we need to fix them. We need to address them and stop having these conversations about, well, what's equity versus equality? And oh, how do we get back to normal? That whole notion of going back to normal should be thrown out the window because normal wasn't working. Normal was not working. And what we've seen over the year is normal caused millions of people to die. And I don't want to go back to normal.
So I think I hear two things in what you're saying, though. I hear
I said a lot. I'm sorry.
No, you didn't. No. You right on point. I think I hear two things. One is that there needs to be an understanding of how that social determinants need to be fixed. And I heard Amos Smith from New Haven, who runs the Community Action Agency here, was reflecting recently on the social determinants of health really needing to be thought of as the structural determinants of health, that those issues that you outlined about housing and transportation are really part of what we are really needing to address. And that I think the other thing that I heard you both say is that one size does not fit all, that it is important if you are going to do this work equitably moving forward, as you're working simultaneously on the structural determinants of health. Also, certain groups need something more, something different. And in the case of vaccinations in Hartford, the decision in Connecticut to follow the CDC age criteria resulted in the average age of Hartford's residents is about 30. And when you start with the 75-year-olds, you don't get a lot of people vaccinated until like this week, right? And you all, and also use of the VAM system, the federal VAM system, when people don't have connectivity, means that you have to use the phone. That you both have talked about the importance of the phone, of giving people a phone to connect them, because they don't have Wi-Fi, either because they can't afford it or because they don't have bandwidth capacity in Northwest Connecticut. So this is what we really need to be grappling with. And I think there's a couple more questions. We're running out of time, coming up on the end. There's a couple of questions in the Q&A. I want to make sure they get asked. One is someone doesn't understand what is meant by integrated care. So if you could say in 30 seconds, and then the other question has to do with bills in the legislature now, that whether there are any bills in the legislature to increase funding to community health centers. And is there any advocacy that folks can do around that? So, and we didn't even get to talk about the American Rescue Plan and all of that. So maybe whoever, Nichelle, maybe you can address the fiscal piece, the funding piece, and maybe you can address the integrated care piece, Joanne.
Sure. So in a nutshell, integrated care is the ability to move patients from, for example, primary care to behavioral health services, and whatever service really the patient needs, because we're making them center to that care. So most integrated care models center on behavioral health and primary care. Most of us, the way we move that model out is to embed behavioral health clinicians into our primary care medical department, and we do what are called warm handoffs. So if we, very important that if you find someone in the moment who wants to engage in mental health services, or you see that there is definitely a need for them to do so, that you don't let them out the door and say, call us tomorrow. The more effective way to do that is to say, let me walk you down the hall and introduce you to our social worker, our licensed clinical social worker, or our psychologist. And let me have them have a conversation with you to see if we can help you further, and immediately engage them in that mental health conversation, and try to get them an appointment so that we're not losing them, because most times it's a scary topic for folks. And really, that's the crux of integrated care, and making sure that you can move your patients through the system where it's needed without losing them while they're wanting to engage in the care.
Right. And in terms of the fiscal piece, I can say in the state legislature, I am not aware of any bills that are being discussed that would address funding for community health centers. So that's a quick answer. And then federally, we did receive federal grant awards, notice of federal grant awards recently last week. But we all know as FQHCs that those grants come with a lot of requirements. So they're very strict about how you can spend the money, what you can spend it on, and when you can spend it. So we're very grateful for the additional funding, but all of that money has to go towards COVID testing, COVID vaccines, and increasing your staffing or infrastructure to address COVID. So they're very strict on how you can spend it. So for instance, if we wanted to do an integrated care model, the only way we could do it would be to tie it specifically to COVID. And HRSA, the federal government would have to approve of that. So, there's some ways that we can be creative, but it all has to be tied to COVID-19. We have talked to the state agencies about funding for health centers, and we have gotten nothing. It's been, well, the federal government is going to send, or the federal government, or we don't have. And then we saw this huge award that was released to hospitals, $41 million, and it was kind of a slap in our face, because we've been doing a lot of work around COVID. We've expanded our operations to now take on testing and mass vaccinations in our communities. And we're very grateful to be able to do it, but most of us are taking huge losses as a result of it, because there's not enough funding to cover it. And when we get reimbursed like $20 per vaccine.
Well, you know, we have run out of time. We're gonna have to leave it there. I think one of the takeaways from this part of the discussion is how the money actually does create the silos, and how that, you know, the funding streams really make it so difficult to create a more integrated, more coordinated and synergistic system that's patient-centered. So we'll have to leave it there, but I want to thank you both from, you know, the bottom of my heart for making time. And really, you are among the busiest people in this state these days. So I really am grateful for everything you do and for taking time to sit with us today. Also, thank you to our audience. We had a terrific audience, great questions, and to our sponsors, EHCN, Donahue Foundation, Connecticut Health Foundation, and Connecticut Community Foundation. Thanks. And I would be remiss if I didn't thank the team at Universal, because we just couldn't do all this that we do without the team of wonderful people on our staff. There's 3 more conversations coming up. The next one is going to be on the role of the public health system as we move forward from COVID. And so watch your emails and your social media, and definitely follow and like Universal on Twitter, Facebook, and Instagram, and stay connected. Thanks again. All the best to you both.
Thank
Thank
you.
you.
Thank you for having us.
Take
Thank
care.
you so much.
Bye.
Bye-bye.